All right, well, thank you everyone for joining today's NCCN patient webinar, Know What Your Doctors Know About Multiple Myeloma. This webinar is presented by NCCN. NCCN stands for the National Comprehensive Cancer Network, a not-for-profit alliance of 31 leading cancer centers across the United States, devoted to patient care, research, and education. The NCCN Foundation is a non-for-profit organization that raises funds for NCCN patient resources, including new and updated patient guidelines, as well as patient webinars like this one. These resources are funded using financial support from generous donors. The NCCN guidelines for patients are based on the NCCN clinical practice guidelines used by healthcare providers worldwide. They explain the same options for cancer care, but are written for patients and their caregivers, family, and friends. You can view and download free copies of the guidelines for patients from the NCCN website. Printed copies of the books can be purchased through Amazon. And if you ordered a free book when you registered for this webinar, you should be receiving it shortly. The Know What Your Doctors Know webinars complement the NCCN guidelines for patients. They cover a series of topics discussed by expert presenters. During the second half of this webinar, you'll have an opportunity to ask questions of the presenters and hear their answers. Now let's meet the presenters for today's webinar. Our first presenter is Dr. Natalie Callender. Dr. Callender is Professor of Medicine in the Division of Hematology Oncology, the Director of the University of Wisconsin Carbone Cancer Center Myeloma Clinical Trial Program, and the Interim Director of the Bone Marrow Transplant Program at the University of Wisconsin's Carbone Cancer Center. Our second speaker is Michelle Lackner. Ms. Lackner is a nurse practitioner, also at the Carbone Cancer Center at the University of Wisconsin. And our third presenter today is Dr. Jim O'Mell. Dr. O'Mell was diagnosed with multiple myeloma in 1997, and he's a cancer research advocate and a retired physician in family practice. Now, without further ado, here's our first presenter, Dr. Callender.
Good afternoon, and thanks everybody for joining us today. I particularly want to also be very enthusiastic to be with these wonderful panelists, Michelle and Jim, who I think are going to give their perspectives and really give you a nice program today. So there are many, many things that we could talk about with multiple myeloma, but I was asked specifically to talk about infections and vaccinations and multiple myeloma. What do we know? So I want to start off my portion by talking about the immune system. And this is a term that gets thrown around pretty loosely. And here on the left are places in the body and organs in the body that we consider part of the immune system. And some of them you may think very logically are. So for example, the little green dots in there are lymph nodes. And of course you would say that's a home that we know of immune cells. The spleen, for example, some people know that that is also an immune organ that sits underneath the stomach on the left side of the body. But you might not realize that the skin is actually an incredibly important part of the immune system that really sort of guards between your contact with the outside world. Lungs have a lot of immune tissue in them. Bone marrow has immune tissue in it, and intestinal tract either as lymph node spots called Peyer's patches and also through the microbiome. And if you look at some of the cells and proteins that compose the immune system on the right here, we divide it into what we call sort of the preformed or the innate system. And these are cells like dendritic cells, mast cells, macrophages, neutrophils, basophils, and eosinophils that are kind of on the ready to fight infection all the time. And there's also some proteins called complement, which actually help puncture holes in bacteria to help kill them. And then in the right circle are what we call the adaptive immune components. And these are cells that learn how to fight infection. T cells are very long-lived cells that can help really drive the immune system. And then, of course, there are B cells that ultimately a portion of them turn into plasma cells, and their function is to make antibodies. So here's a plasma cell picture, and this is plasma cells are normal cells in the body, and it's these cells that actually go bad, if you will, in multiple myeloma. Normally their job is to make antibodies. And so you can see on the left is a cell. It has a nucleus, but then it has this sort of squiggly stuff in the right. And that's really kind of a factory for antibody production. And these antibodies are manufactured in all sorts of flavors, if you will, and released into blood, into saliva, into urine, and all sorts of secretions to help fight off infection. The antibodies that are made, either if the plasma cell is normal or malignant, include the blue part here on the right called a heavy chain. And this normally can come in 5 different types: IgG, IgA, IgM, IgD, and IgE. And then in the pink salmon color, those are what are called light chains that are connected to the heavy chains in normal antibodies. And those are either designated kappa or lambda. And every person makes all sorts of different antibodies that are directed against all sorts of different things, different bacteria and viruses. And if you look at what the job is of normal antibodies, they're incredibly important. So antibodies can neutralize things. So for example, they can bind to viruses or bind to the toxin that viruses make and just sort of take them out of action. They can also serve as a way to get those hole punching proteins that complement over to bacteria, so that can happen. And then they also do this fancy thing called opsonization. But if you think about it, it's a way of sort of decorating bacteria with signals so that in this particular slide, the blue cell, what's called a phagocytic cell, will come over and eat that whole glop of bacteria and get rid of it. So antibodies are incredibly important. Now, why are people with myeloma at increased risk for infection? So we think of myeloma as a disease of immune dysregulation. And unfortunately, infections are very common in multiple myeloma, both at diagnosis, and we often see people who will say at the time they're diagnosed, they've been having infection after infection over a series of months or even years, and then finally they're diagnosed with myeloma. But you can also get infections soon after treatment. And once you put aside myeloma as a cause of death, the #1 cause is actually infections. And we know through studies that have been done of large populations that compared to people of the same ages, if you have myeloma, your risk of a bacterial infection is 10 times higher, and a viral infection 7 times higher than people of the same age. And during the first year of treatment, your risk of bacterial and viral infections is 11 times and 18 times more, respectively. And a substantial portion of people who end up dying from myeloma early on, it is related to infection. And if you look at some of the common regimens that we prescribe people, so for example, lenalidomide and dexamethasone, or bortezomib, lenalidomide and dexamethasone, these regimens during the first year can be associated about 1/3 of the time with grade 3-4 infections, meaning infections bad enough that you would have to receive IV antibiotics or potentially be admitted to the hospital. So this is a pretty common theme. So why is that increased risk of infection there? Well, many people with myeloma display a phenomenon that we term immunopoiesis. And what that means is, although they have a large amount of antibody, that antibody is abnormal. That's that M protein that you might have heard about. And then what happens is normal antibody levels actually go down very, very low, so that they're kind of paralyzed, or that paresis. And then other immune cells, some of which I mentioned in that first slide, like B and T cells and dendritic cells, they seem to function less well when you have myeloma. The drugs that we love to use, dexamethasone, everybody's least favorite drug in myeloma, that causes itself a risk of infection and alters the function of immune cells. And then there's the symptoms that the disease itself causes. So for example, if you have a new compression fraction, or maybe you have fractured your arm or your leg because of your myeloma, you're not getting around as well. And just being more sedentary puts you at risk for infection. The chemotherapy, besides steroids that we give people, also causes a risk of infection. And then myeloma is a disorder of older people. So the average age of somebody diagnosed with myeloma is about 69. And we know that everything else being equal, older people have a higher risk of infections, regardless of their underlying medical problems. And finally, we sometimes talk about a term called frailty in myeloma. And what that means is, how much has your myeloma affected your normal function? In other words, are you able to get around? Could you drive a car? Could you take a bus? Could you handle some of your day-to-day problems? And people who can't do that, if they are considered more frail, they're also at risk for infections as well. So what are strategies to potentially change this? And so we have over the years sometimes offered people antibiotic prophylaxis. Now I'm talking about drugs to fight bacteria, not drugs like acyclovir that are antiviral drugs that are typically offered to prevent shingles, but antibiotics. And there have been studies that have suggested that using antibiotics, particularly a drug for example, like levofloxacin in the first 3 months after diagnosis, can help decrease the risk of infection. There was also recently what's called a meta-analysis, where you put together results from many trials together to try to see if you can find the real result. And again, it suggested that being on an antibiotic to prevent infection lowers the risk, but unfortunately did not prevent death from infection. So sometimes some of the providers will prescribe antibiotics. Again, this does not include antiviral agents that are often prescribed particularly if you're on drugs like a proteasome inhibitor. Now, what about influenza vaccines? So it's November and we're about to enter flu season, and outside of or before COVID hit last year, influenza was by far the #1 respiratory infection during the winter months, and one that causes a lot of problems. So again, about 30 to 40 million cases a year in the US, and of those about 20 to 50,000 deaths. Now, we know that people with myeloma, if they are given a flu vaccine and all you're doing is measuring antibody levels, they don't seem to respond as well as other people. So in a couple of different studies, somewhere around 1/5 of people had antibodies against flu. Now, that doesn't mean that they didn't have any protection at all, but if you're measuring antibodies, they didn't seem to do as well. There have been some studies that have suggested if you get 2 influenza vaccines in a season, perhaps a month apart, that you can increase your rate of having antibodies against influenza. So that might be a very good thing. Sometimes, however, and we found this in our own hospital, it's difficult to get that second flu shot paid for, and something that we are hoping on a national level we can change. Now, we also know something very interesting from a study called the INSIGHT study. And what this study did is it looked at myeloma people from around the world in 15 different countries, 4,300 patients, and tracked them looking at all sorts of things. It wasn't an intervention, it wasn't a treatment, but it was sort of looking at how they did over these 3 years. And what we found is that the rates of flu vaccination varied quite a bit from regions in the world, from a high of 56% of myeloma patients in the US to a low of 4% in Asia. And the same thing for pneumococcal vaccinations, 43% in the US compared to 5% in some of the other countries. But if you look at all types of causes of death in myeloma, if you're looking just at pure survival, it turned out that people who were vaccinated for both influenza and pneumococcal pneumonia actually had better survival. And if you look at specifically people who are infected with influenza or pneumococcal pneumonia and hospitalized, the patients who were not vaccinated had about a 20% death rate from those infections versus about an 8% if they were vaccinated for flu and 9% for pneumococcal pneumonia. So again, really underscoring the value of getting vaccinated for these two things. Now, another interesting phenomena is if you've had an autologous stem cell transplant, you may have received a recommendation to get revaccinated. And some people think that that may be a waste of time. This is some data from the University of Rochester looking at people who underwent an autologous stem cell transplant for their myeloma. And then they looked after vaccination as to whether or not they had a response, or also if they weren't vaccinated at all. And the people who had a response to vaccinations, shown in the dotted lines, actually seemed to have better control of their myeloma and better survival. So we don't know exactly if this is cause and effect, but we certainly think this kind of information is really something to consider when you get that recommendation for revaccination after a stem cell transplant. Now, I'm going to show you right now a graph from the Centers of Disease Control that shows you the suggested vaccinations for all age groups except for children in the United States currently. And if you focus on the right side of this graph, you can see, of course, flu shots recommended for everyone. There's also a vaccination called tetanus, diphtheria, and pertussis, or Tdap, recommended every 10 years. Measles, mumps, and rubella, a live vaccine that is recommended perhaps once in a lifetime. There is the recommendation for varicella, meaning shingles, and also pneumococcal PVC-13, which is also known as Prevnar, and the pneumococcal 23. Now, this is a recommendation for people just without myeloma. And as you may know, after a vaccination, after a stem cell transplant, we do recommend that you go through, some people like to call it their baby shots, through a series of lots of these, including zoster vaccines, particularly what we call the recombinant one that's now referred to as Shingrix, and that was one that we recommend people. The live vaccine MMR that's listed here, we usually try to withhold until about 2 years after a stem cell transplant. Now, some special considerations are that, as I mentioned, we believe everyone after stem cell transplant, whether it's autologous or with a donor, that would be called an allogeneic transplant, should get revaccinated. And also after CAR T therapy, something that is becoming more common for treatment for myeloma. There's a series of this. I did not include a slide today of the recommended order that these should be done, but typically they do start with the flu and pneumococcal vaccines that we think are the most important, and include all of the ones that were on the list, including hepatitis B and the vaccinations, the Tdap and the MMR. We do think that myeloma patients, if they can get it, should consider a high-dose flu vaccine annually. And as I mentioned, there is emerging data that 2 doses, usually given a month apart, would be better. Now, what about COVID? This is obviously a topic that's on everybody's mind. And this is some data provided to us from our infectious disease experts here at the University of Wisconsin. And what we're looking at is a comparison to people who are considered healthy controls, that is not getting various treatments. Those are the people in the dotted line. And this is basically saying that getting an mRNA vaccine, 2 doses, so that would be either the Moderna or Pfizer, that you have about a 95% chance of developing antibodies against COVID. But if you have one of these situations shown here below, perhaps you're on immunosuppressive therapy, you had an organ transplant, you're on hemodialysis, or you have cancer, your antibody response seems to be lower. And in particular on the left, if you focus on the dark blue dots, the percentage of people developing antibodies really varies from a low of about 40% up to some people having close to a normal response. So if we look at this a little bit closely, now some people look at this data and say, well, what's the point of getting a vaccine for COVID if I might not have as good a response than as a person without myeloma? So there's data like this that I think is quite important. And this is data presented last year. And this really occurred before we had vaccinations by Dr. Chari from Mount Sinai. And if you look at this, this is people with myeloma who had COVID and what happened to them. And this is data accumulated from a number of countries that you can see there in panel A. Most of these are from Europe. There are patients here from the US. But if people with myeloma got COVID, compared to normals where the death rate has been in the neighborhood of 2 to 4%, it's quite sobering information. So you can see in the US, of myeloma patients in this particular study, 27% died if they developed COVID. In the UK, almost 60% of myeloma patients died, and in France, about 38%. And that risk of death increased with increasing age, and it also increased, as shown down here in panel D, if you had other features of your myeloma that can portend for more difficulty. And that would be more advanced stage, having higher risk myeloma, having kidney problems from your myeloma, and having what we call other comorbidities, things like diabetes and heart disease, and also having myeloma that is not in remission at the time the COVID infection occurred. So this is, again, why we want people vaccinated, because we think the outcomes, if a person develops COVID, can be quite severe. Now, again, there's a lot of misinformation or poor information about responses to COVID vaccines. So this is a study done exclusively in myeloma patients, 103 of them, looking at antibody responses to either the mRNA 1273, that would be the Moderna, or the Pfizer vaccine. Now, what you want to take away from this is both vaccines were helpful. And sometimes people say, well, don't we all have natural immunity to COVID and we just don't know about this? In this particular study of 103 patients, only 2% actually had antibodies to COVID prior to vaccination. So that sort of busts that theory. But based on what the experts would say, only about half the patients had what we would consider in just 2 doses an adequate response. Now, this particular study, which is small, suggested that perhaps the Moderna vaccine might have been slightly more effective, but these numbers are very small. But I think what you take away from this study, which came out recently, is that that booster is quite important. We do know that not every person, but many people getting that booster really have a good chance of increasing their antibodies against COVID. And so we strongly recommend that. Now, we know that some treatments that we give people with myeloma are very impactful on the development of, on the ability to develop anti-COVID antibodies. And in particular, the drug daratumumab, which is clearly one of the best drugs we have for treating myeloma. And there's also isatuximab, another anti-CD38 antibody. These drugs affect not just antibody production from myeloma cells, but also normal cells as well. And so it does look that people on daratumumab seem to potentially have a lower response to a COVID vaccine. And again, strongly recommend that booster shot. And then people going through CAR T transplants also seem to have a lower rate of response to COVID vaccines. And that's why relatively recently the recommendation has come out that even if you were vaccinated for COVID prior to your CAR T transplant, you should go through the whole series again. That is 1, 2, 3 vaccines for COVID. And of course, if a person is really doing poorly with their myeloma and have been through many, many treatments, that also may affect their ability to respond to a COVID vaccine. So what do you do to get to protect yourself as much as possible? Well, if you haven't gotten the message here, vaccinations, we really, really think they are good things, that they have made a huge dent, a huge change in the world's health over the years, and we think they are very good for people with myeloma and really probably not utilized enough. You definitely should be revaccinated, all of those baby shots after a stem cell transplant, either autologous or allogeneic or CAR T. You can also try as much as you can. We're getting into the holiday season, but really to have a healthy lifestyle. And by that, fruits and vegetables, some sort of exercise, whatever you can do is great. If it's chair yoga, wonderful. If you can walk, great. Also, sleep is important. Making sure that you really can get, 7 to 8 hours a night is considered ideal. Some patients may benefit from the use of things called passive immunity or intravenous gamma globulin. That is actually infusing antibodies on a monthly basis. And then I think there's pretty strong evidence that things like social distancing and mask wearing have been helpful. I think that's why we didn't have any flu last year. We'll see what happens this year. And certainly we think that those are important still in high-risk situations. So let me stop there and turn over the talk to Michelle.
So kind of capulating off of what Dr. Callender's last slide did, I'm going to talk about myeloma and exercise, nutrition, and supplements. So we're just going to briefly go over normal bone health and talk about how myeloma affects this, and then discuss myeloma, exercise, nutrition, and supplements. So just briefly to kind of talk about what happens in a normal skeleton. I think I wanted to put this slide in because I've always thought of your bones once you reach adulthood as they're not growing and they're not changing, but they actually are constantly regenerating. And there's 2 main cells that lead this process, your osteoblasts and your osteoclasts. So your osteoclasts, I like to think of as your Hoover vacuum. They're going through and they're getting rid of those old cells that have just sort of reached their terminal lifespan. So they kind of go through first and they're cleaning up old bone debris. And then you have your osteoblasts that come in and they form this matrix that will eventually mineralize and harden and form new bone. And when these two cells work in harmony, you actually regenerate your skeleton every 10 years as an adult. So that's just an interesting little fun fact. So what happens in myeloma, and we don't know exactly why this happens, but myeloma plasma cells produce this osteoclast activating factor. And basically what it does is it turns on the osteoclasts. And from the last slide, those are the Hoover vacuum. So the osteoclasts are working harder and actually destroying, breaking down the bone. And at the same time, they're inhibiting the osteoblasts. So you're also making it harder for your body to try and heal afterwards. And that's sort of the worst case scenario as to what happens with the bones. So how common is bone disease in myeloma? It's very common. Approximately 60% of patients at diagnosis will have these myeloma-lytic bone lesions. They're most common in the central skeleton. So this is your back, your neck, and your pelvis, although they can be in the extremities as well. And they obviously cause a lot of pain. Even if your bone hasn't fractured, having these lesions in your bones is painful to the bones. There's nerves in your bones. The pain is usually worse with movement. It's usually better at rest or when you're sleeping, with the exception of the fact that you got to get into bed and you got to roll over in bed and you eventually got to get out of bed. And all of that is incredibly painful with these bone lesions. And I also wanted to put in the fact that we talked about 60% of patients have these lesions at diagnosis, but 80% of patients will develop them during the span of their disease. And what that means is that even if you don't have these lesions at the beginning, you can develop the lesions as time goes on. So what do you do to treat the lesions? You first got to treat the myeloma. You've got to get these plasma cells out of there so that you stop activating the osteoclasts. And then bisphosphonates or denosumab is also recommended and helpful for osteoclasts, disrupting osteoclast activation. Exercise in myeloma patients in terms of bone regeneration is not well studied, but what exercise definitely does do is help strengthen muscles. It helps with balance. And if you can strengthen the muscles and get some of that work off the bones, you actually can help with the pain associated with myeloma bone lesions, even if it's not necessarily directly causing bone regeneration. So NCC guidelines for supportive care is a category 1 recommendation for bisphosphonates or denosumab, and people should remain on bisphosphonates or denosumab for at least 2 years and potentially restart if they have a relapse with a new bone lesion. But what can I do to strengthen my bones? The first thing is, calcium and vitamin D. This is going to be something that you need to have a discussion with your physician about. Around 1,000 to 1,200 milligrams of calcium is recommended per day, depending on your age and sex, and 600 international units of vitamin D under the age of 70, 800 above the age of 70. But this is not just supplements. It has to do with what you're also taking in by way of food. And so having your physician be aware to talk about how much supplements, potentially getting hooked up with a nutritionist that could help examine what you eat on a daily basis and help make recommendations. But both vitamin D and calcium do help strengthen the bones. The number one thing, if I had to recommend anybody for what they could do to strengthen their bones, it would be to quit smoking. Smoking in and of itself is associated with osteoporosis. It causes bone demineralization. And so it's just one more thing working against your bones. So if you haven't heard that one already, we would definitely recommend that you quit smoking. Physical activity is weight-bearing exercise, and it has been studied pretty extensively in osteoporosis patients, and it has been shown in that setting to increase bone mineral density. So now again, it has not been studied specifically for multiple myeloma, but in general, if you didn't have cancer, weight-bearing exercise does help strengthen your bones. But more importantly, again, it improves your muscle strength, it improves your tone, and overall, it improves your activity tolerance. And this is also particularly important if you're somebody that's thinking about going through one of those more intensive therapies, like an autologous stem cell transplant or a CAR T transplant. You do need to be stronger in order to be able to go through procedures that are going to be pretty debilitating. So anything you can do to get yourself stronger before you go through the procedure is helpful. And then in general, Anything you can do to strengthen your muscles also will help with balance, and that in general is going to reduce your risk for falls. So again, I said before, exercise has been studied in terms of osteoporosis. There have been benefits seen. They're talking about moderate intensity exercise. So this is as simple as going for a walk outside, hopping on an elliptical trainer, going for a swim or water aerobics, or riding a bike. So it doesn't have to be anything fancy. It's just exercise that gets you out and gets you moving. Is it safe with multiple myeloma? Because I think that's a very common question that we hear. The majority of the studies that have been done with regards to exercise and multiple myeloma have tended to be done on patients after they've been through treatment, and usually induction chemotherapy and then the autologous transplant. Certainly in that population, it has been found to be safe and effective, and no significant adverse reactions to exercise were reported. I was able to find a couple of very small studies. The one that I gave here as an example, it's a very small study, 41 patients. It did see an improvement in fatigue, but the biggest limitation was that patients with pathological fractures were less likely to participate because of pain, which is what would be expected. So my takeaway message with regards to exercise and myeloma, there's relatively limited data. Exercise is easier and possibly safer after you've gone through treatment with multiple myeloma. It's really important for you to talk with your physician before you start this exercise regimen. You know, depending on where bone lesions are, depending on what you as an individual are dealing with, will help guide what types of recommendations are made. It's really important for you to know your limits and to let pain be your guide. If you're doing exercise and you start getting worse pain, a really sharp, intense pain, you need to stop doing that exercise. So again, we talked about swimming, walking, biking. The goal for exercise is the goal for anyone. It's 150 minutes per week, which can be broken down into 30-minute sessions 5 times a week. But I also think it's important to know that studies have not been shown that it has to be 30 uninterrupted minutes. You can split up that 30 minutes into 3 10-minute sessions. There's lots of reasons why people can't work out for 30 minutes. Sometimes it is endurance, it is activity tolerance. Sometimes it's that you're working or you have kids at home or grandkids at home. It's just as effective to do 10-minute sessions 3 times a day as it is to do one 30-minute session. Balanced exercises are important. Again, we want to do everything we possibly can do to prevent you from falling. And it can start out very simple with static exercises, which is just simply standing in place, washing the dishes, helping with meal prep, or standing at the stove and cooking. And you can progress to one-legged balance exercises or sidestepping or backstepping with support. And eventually you can eliminate the support aid. I think if you're at the point where you're needing to do some balance exercises, that's also a really good opportunity to talk with your physician about what's going on at home, because physical therapy can be really helpful with balance exercises, and you might have the ability to get in with a physical therapist so that they could really target those exercises specifically for you. So we talked about aerobic exercises, we talked about balance exercises. I'm going to spend a little bit of time on core exercises. These are the muscles in your back and your abdomen and pelvis, and they're basically what help you sit up in your chair. They help you stand up. They help you lay back in bed. They really do help with balance and stability, but they make those everyday activities easier if they're stronger, and they're not as focused on when you go for a walk or when you ride a stationary bike. So core strengthening exercises can be helpful. And again, if you help strengthen those core muscles, you take some of that pressure off of the bones in your back, and it can really help with back pain. So I put in some slides here with some examples of exercises. And like Dr. Callender was saying in her talk, it doesn't have to be that you're standing up for it or you get down on the ground. That's why I included these slides to show you ways that you can do some of these exercises sitting in a chair. So seated twists, side bends, seated lifted knee lifts. This is another example. Again, you can start out with lifting one leg at a time, and as you get stronger, you can start lifting both legs up at the same time. You can do them on the ground, but it's just as effective to be doing it in a chair, and it's a little bit easier to get up and down from. This is Superman. This can really help strengthen your back muscles, but again, it might be hard to get down all the way onto your stomach. You can do them on your hands and knees. So there's an example there to the right. The bridge can be very helpful at strengthening your pelvic muscles and your abdominal muscles. You always start with these exercises just with your own body weight, but as you got stronger, you can put some weights across your pelvis to help make it a little bit harder. But again, always start with just your own body weight. Downward facing dog not only helps strengthen the back and abdominal muscles, it can also help with quadricep and hamstrings, but you don't have to do that position. On the right, I've got some ways there that it can be modified. It can also be a really nice stretch for lower back. And so sometimes when you do this, you do it 3 or 4 times in a row and you can feel your back stretch out, and it really can help with pain. The plank is a great exercise for back and abdominal muscles, but it can be very challenging. You absolutely can do it on your knees. You can even do it in the example on the bottom to the right there against a countertop. You want to make sure whatever you're leaning against is bolted down to the ground or to the wall so that it doesn't move, because we don't want to cause a fall. But you can actually get a lot of that same effect just balancing against something like that. Tree pose is another one that can help not only with quadricep and hamstring, but also abdominal muscles and back muscles. You don't have to assume the position like the lady on the left does. You can have your foot down on the floor, or you can use a chair to help with balance and still be able to do it safely. Cat-cow is another back and abdominal muscle. It's also a really nice stretch for your lower back. And again, you can do it in a chair. Just a brief slide about diet in myeloma. There is no specific diet that's been shown to be effective at treating myeloma. The biggest thing that has been found is there is a relationship between obesity and increased mortality in multiple myeloma patients. So if there was one recommendation with regards to diet that I would have, it would be that if you're overweight or obese, that you work to try to achieve a normal body mass index. Weight loss should always be gradual. We're talking 1 to 2 pounds per week. And in general, you should enjoy a varied diet that includes lots of fruits and vegetables, as well as healthy fats, lean proteins, and complex carbohydrates. And then lastly, in terms of supplements, there has been no specific supplements that's been shown to be beneficial in either the treatment of myeloma or decreasing morbidity and mortality. And it's important to remember that supplements, vitamins, and minerals can interact with chemotherapy. They can inhibit the chemotherapy, and they can potentially increase the side effects for chemotherapy. So it's not that you can't take them. It's more important that you're really honest with your physician about what you're taking, not just prescription medications, but over-the-counter herbal supplements, anything that's compounded. We want to know what you're taking. And it's even helpful if you bring in bottles. This is especially for complex vitamins or mineral combinations, or some of those compounded herbal medications. We don't know what's in them. You might say a name, but we don't know what that is. And it'd be really helpful to be able to read what's on the bottle, to know what's in it, and be able to check to see if there's any interactions. And then it's also important to remember when you get side effects, especially if you started a new supplement, it might not be from the chemotherapy or the myeloma. It actually could be the supplement that's giving you the side effect. So with that, I'm going to turn my presentation over.
Hello, everyone. I've labeled my short talk, Building Your Myeloma Support Team, because that's what you need to survive this cancer. A good team to help you. When patients are diagnosed with multiple myeloma, the majority have never even heard of this cancer. Myeloma, however, isn't rare. Across the United States, a patient is diagnosed with myeloma every 15 minutes. As we get older, our hourglass runs lower and lower on sand. Our time on earth diminishes. Life teaches us, and myeloma definitely teaches us, to use and enjoy every day which God gives to us. Thank you to Dr. Callender and to all myeloma physicians who conduct clinical trials for the additional months and years of time which your research has secured for us. Time is precious. Don't waste it. When we face myeloma, we can't accomplish all that we need to learn and do alone. Each of us needs a team. How carefully and thoughtfully you pick your own team will impact your care, possibly even your outcome. Before we look at the members of your team, the gears on this graphic, first look at the bottom of the slide. You need to know where there are good, trusted sources of myeloma information. I would strongly suggest you discover the IMF at myeloma.org and HealthTree University, Jenny Ahlstrom's amazing source of myeloma knowledge presented by world-renowned experts, can be found at healthtree.org. You can also find factual information from the NCCN, online or printed. The print edition, which John Murphy just mentioned earlier, has just been updated. You need the best players in all positions. I like this graphic because it points out many of the key people on your personal treatment team and how interconnected they are. You need skilled people who can work well together in your everyday myeloma treatments, and especially when a crisis arises, such as kidney or heart failure secondary to myeloma, or the drugs we use to treat myeloma. Some parts of your chosen team are obvious, so let's begin with the two most important members, your caregiver and your doctor. Caregiver, who coordinates your care? At the center of this graphic are both the caregiver and the patient. Individual patients don't have to take all of this on. Trust your team, especially your caregiver. I have lived with this cancer for 24 years and have led a support group for 22. As I teach my group every month, I've observed that the caregivers tend to be the most avid note takers. They ask the most questions. As they face myeloma together, the patient and their caregiver, nearly always a spouse, are a team. They are inseparable, and the decision on treatment is their dual decision. I like the color association on this graphic, which recognizes the team nature of patient and caregiver. Number two, your doctor. This may seem simple, but is it? What kind of doctor do you need? I would submit that you need more than one doctor. First of all, you need a family physician or a general internist. This is the doctor on the right side of this slide who will most likely make your initial diagnosis of multiple myeloma. He or she must be trained in sorting out chronic pain, abnormal labs, and the multiple possible presentations of this cancer, which can be so hard to initially diagnose. They are also trained to pick the best subspecialists for your myeloma problems, if that becomes necessary. The second kind of doctor you may need is a local hematologist-oncologist. Once your family physician has made the diagnosis, you need the expertise of a local or regional hem-onc. They will do the blood and marrow testing to confirm your diagnosis and should know what FISH, cytogenetic, and lab studies to order to categorize your risk status. They can check NCCN guidelines and choose initial therapy for you. However, very few local oncologists know all the nuances of current bispecific BCMA and immunotherapy, which BCMA or GPRC5D antigen antibody clinical trials are currently available in your geographic area. They will not know the most recent NCI, French, Spanish, or Italian myeloma clinical trial results. For that, you need another key doctor on your team, a myeloma specialist such as Dr. Callender, who is the person in the gear right beside you on this graphic. This should be the person who provides up-to-date worldwide myeloma information so that you can make informed treatment decisions at every step for the rest of your life. You need to see this person soon after diagnosis, at relapse, and periodically when big treatment decisions need to be made. As good team members, your myeloma specialist and your local doctor should always confer and work together for your benefit. Major decisions can come from the specialist like Dr. Callender, but required labs and treatments can conveniently be given locally. My next slide enlarges your team to the rest of the people you will need and some of whom you may need. An oncology nurse, nurse practitioner, or physician assistant. Nurses can suggest treatments for myeloma-related symptoms and myeloma drug side effects. They will be your first point of contact for day-to-day treatment-related concerns. Develop a good relationship with them because you need them. You'll often spend more time with an oncology nurse or a nurse practitioner such as Michelle than you will with your doctor. Social services financial assistance specialists. These professionals will be familiar with most of the drug company patient assistance payment programs. As you know, our drugs are very expensive. Specialty pharmacy or pharmacists. Many of the drugs we use cannot be purchased from our local drugstores. They must be purchased through specialty pharmacies and have specific requirements such as REMS programs. Think back to when you were worried that your Revlimid wouldn't arrive at your front door in time. You need a reliable specialty pharmacy, and some are definitely better than others. Dentist. Myeloma patients with bone disease, the majority of us, will need bisphosphonate or denosumab therapy to protect our bones from the destructive effects of osteoclasts. Michelle just explained this very effectively. While this therapy has proved quite beneficial, there is a risk over time of ONJ, osteonecrosis of the jaw, a destructive loss of the mandible or jawbone. It's essential that every myeloma patient beginning bisphosphonate therapy see a dentist first. Get any dental work completed before your first dosage is given. A myeloma coach or mentor. I would strongly suggest that you partner with another myeloma patient who is experienced in the disease. Rely on him or her for unbiased information. Sources where you can find these trusted members of your team are the LLS First Connection Program, Myeloma Crowd's Myeloma Coach Program, and a good member of a local support group. Multiple myeloma is a very individualized disease. The people you need on your team may not be the same as someone sitting beside you at a support group meeting needs on their team. Let's quickly touch on those other possibly needed team members. Cardiologist. A heart doctor specialist may become necessary if you were given a myeloma drug such as carfilzomib, which can affect the heart. Nephrologist. Myeloma can adversely affect kidney function, one of the CRAB criteria for diagnosis of this cancer. Nephrologist is a specialist who treats kidney disease. Ophthalmologist. This is a possibly needed doctor on your myeloma treatment team. One particular drug, Blenrep, can have a side effect involving the cornea of your eye. To receive this drug, it's essential that you have an eye specialist on your team. The drug, by the way, is quite effective. Orthopedic surgeon. My myeloma presented with a fracture of one of my vertebral bodies. My spine was unstable, and I could have been paralyzed if treated incorrectly. An orthopedic surgeon and I had to jointly decide whether I should be treated with a special brace or spine surgery with a Harrington rod. Neurologist. Both myeloma itself and the drugs used to treat myeloma can cause damage to nerve tissue, something we call neuropathy. Often this painful condition can be improved with dose reduction or by changing drug treatment altogether. Some neuropathy can be so debilitating, however, that a nerve specialist, a neurologist, might become necessary. I would like to add that the best way to treat neuropathy is to avoid developing it in the first place. Tell your doctor or nurse at once if these symptoms are worsening. Pain management or palliative care. I would describe this team partner as someone who makes life better for cancer patients. They seek innovative methods to help alleviate your pain, and they also employ holistic approaches to help symptoms beyond just pain. When you look at the slide, you'll see that there are other possible members of your team, including physical therapists, nutritionists, mental health professionals, spiritualists, and others. Each person's myeloma is unique, and each patient's needs are unique. In summary, I've tried to give you information on the various members whom you might need on your support team. As you assemble your team members, I would also remind you to keep an ongoing file of your medical record. Whatever method you choose is the best one for you. Maybe an old school binder, maybe an electronic patient portal, maybe copies of imaging results on a disk. That's an excellent way to give information to a subspecialist if you need to see one. Finally, I want to wish the very best of luck to you, fight against myeloma with the help of your assembled treatment team.
Thank you, Dr. O'Mill. That was great. And I want to thank our other presenters, Michelle Lackner and Dr. Callender. Now it's time for our Q&A session. Our first question, many multiple myeloma patients ask about supplements to improve your immune system. Do you have any suggestions about that?
That is a great question. And I think it's one where there's the natural tendency, of course, to try to do anything you possibly can to help with your myeloma. And I don't think that really there has been any supplement that has been shown to be helpful in boosting the immune system. I would say that there have been historically some studies where they looked at, in other types of cancer, using mega doses of vitamins, for example. So there was a study done in head and neck cancer when they were giving extra vitamin E and vitamin A, and that actually turned out to be a negative study. In other words, super doses were actually associated with a higher risk of that particular type of cancer coming back. I recently saw an individual who had really high calcium, and as many of the people attending this conference might know, that high calcium can be associated with a myeloma relapse, and that's what we were worried about. And it was just odd because the patient was doing fine and it was just really confusing. And then it turned out that the patient had been prescribed by a local practitioner supplements that contained an enormous amount of vitamin D. So this individual was actually driving up their calcium to dangerous levels, causing kidney problems related to supplements. And the person, in all good faith, thought that was a good thing to do. So I think I have to say the other thing about supplements, and Dr. O'Mill may also have a feeling about this, they're not regulated. There is no FDA approval process for supplements. And so there isn't any guarantee that even what's on the label is actually in there. So I would really be very hesitant about any supplement. There are, some of the things your mom told you are really still true. Getting your fruits and vegetables are good. Fiber actually looks like a good thing to do for your microbiome. But I think, and particularly spending a lot of money on supplements, I would very much discourage. And I don't know if you Jim and Michelle, if you have thoughts about that as well.
I think that's an excellent answer, Dr. Callender. And I would even say that there are supplements that can be harmful. An example is vitamin C when a person is taking Velcade. When you're taking Velcade or bortezomib, a high dose of vitamin C can actually counteract the effect of that drug. So not only are supplements not necessarily helpful, sometimes they can be harmful. So I'd summarize by saying if you do want to take a supplement, or if you're taking a supplement, be sure to share that with your doctor or nurse as you're doing that.
Okay, great. Dr. Callender, this goes back to your talk. What is considered to be an adequate antibody response to the COVID vaccine?
Oh boy, that is a great question. You know, we're still learning all the time about COVID vaccinations and responses. There are a number of commercial assays out there. Some of them are felt to be more semi-quantitative. In other words, they're just going to tell you positive and negative. Some actually give you a range. I think that that's something that we don't know for sure. And it's even there's a debate going on among experts if you should even be testing for this. And of course, I think we don't know. We are interested to see if people have antibody responses. And some of your audience may know that the Leukemia Lymphoma Society put together a large study looking at responses to vaccines. Health Tree has also been interested in this question. Now the NIH is getting involved. And so I think we're going to try to find out whether levels make a difference or not. But I think it's very unclear at this point. And I think what is also unclear, if you're a person who for whatever reason had a COVID spike. Now we're not talking about the nucleocapsid, that's the antibody test if you've had an infection, but if you have a spike antibody test looking at whether or not the vaccine produced an antibody response and it's negative, I think then, you know, there are people who believe that that is not capturing all the ways a vaccine can be protective. In other words, there may be T-cell immunity. So I think we just don't know for sure. And I think we're hoping to get more information. But again, I don't want information like this of low titers or whatever to discourage people from getting vaccinated, because it's really important that everybody get vaccinated.
Right. Okay, question from Lindsay. She says, great presentation. My dad was recently diagnosed with multiple myeloma and is on both chemo and hopefully temporary dialysis. He's been struggling with fatigue, and we read about ginseng supplements to help with this. Is that something you recommend?
Anybody want to take that?
Yeah. Michelle, do you know anything about ginseng?
I was just trying to look it up really quick. I mean, it's not one of the ones that immediately goes to my mind as one of the ones that can interfere with. I mean, a lot of the herbal supplements can also interfere with platelet, not platelet production per se, but the platelets functionality. And so depending on what therapy you're on, when you're on aspirin, when you're on an anticoagulant, there's a lot of herbal supplements that interfere with those and put you at a higher risk for bleeding. I would almost have to look into it, but I think I speak with what Dr. Callender had said earlier, and I apologize, my computer decided to shut down. But you know, the other problem with herbal supplements is you don't ever know exactly what's in them. And you can start with one bottle, and then when you go to get your next bottle, what's in it actually could be different. They're not regulated the way prescription medications are. So I think you just have to be very cognizant of that. And then also, you know, again, it can interfere, it can prolong chemotherapy, it can make you have more side effects than what you're already having. I would generally prefer a multivitamin, and then lots of good fruits and vegetables and a varied diet is probably going to be the thing that will help your energy the most, as well as getting in a little bit of exercise, going for a walk. It doesn't seem like it in the beginning, but with time, you actually really truly do get stronger and you have more endurance, and it seems counterproductive, but going for a walk or doing some light exercise really does help you feel better and have more energy.
And I will say, ginseng has been studied and actually can help with nausea. That's a property that does seem to be there with ginseng. However, unfortunately, dialysis, many people report a lot of fatigue when they're on dialysis, and some more than others. Some people report just the entire afternoon after a session, they are really wiped out. This is something that you might have your dad bring up with their physician. Sometimes people get very low blood pressure after dialysis, and that's something that can be addressed. Sometimes they're having excessive fluid removed in their dialysis sessions. And I wish it was true for every person with myeloma who comes in with kidney failure requiring dialysis. But these days, many patients can get better and can get off dialysis. So hopefully that is temporary. But that procedure itself can also certainly cause side effects, and that may be a big part of it too for your dad. Finally, you may want to talk with him about how anemic he might be. Again, kidneys make a hormone that helps make red cells. And so sometimes when people are on dialysis, they tend to get somewhat anemic. So those would be some suggestions that perhaps you could bring up with your dad's doctors and providers.
Okay, great info. Ray says, I experienced a cataract post-stem cell transplant and will be having cataract surgery next month. Are there any prophylactics that I should discuss with my ophthalmologist to avoid possible infection? Jim, Dr. O'Mell, you talked about eye care. Would you be able to answer this one?
I think I can add something to the picture. Cataracts are certainly a process of aging, but they're also definitely made worse with steroids. Almost all of us who begin myeloma therapy get dexamethasone. Dexamethasone is a two-edged sword. It has a good sharp side that kills myeloma cells very effectively, but it also has a destructive side that can cause osteonecrosis of the hip joint. It can cause cataracts. It can cause ulcers. So cataracts certainly can be one of the side effects of long-term steroid dosage. As far as cataract surgery, I don't think there's anything I can say as far as relative to myeloma. I don't know, perhaps Dr. Callender, you can add to that, but I do know that steroids and cataracts are certainly related to each other.
Yeah, I mean, I would agree with that entirely. I mean, fortunately, cataract surgery has become fairly straightforward. A lot of it is automated even, and that it depends on your ophthalmologist. Some people will ask you to hold chemotherapy for a week before, a week after. That's probably not necessary. The nice thing about cataract surgery is most of the time people are instantly better. They notice a huge improvement in their vision if that's what's affecting it. So I think I don't know that there's and usually if you're getting a cataract procedure, you are prescribed a series of drops, typically to use both a week before the procedure to help with swelling. Some of them, there's actually typically an antibiotic prescribed. I know that's what our ophthalmologists use. So they do give you antibacterial eye drops before the procedure and then some weeks after. So that's something you can certainly discuss with the ophthalmologist.
Okay, Judy asks, writes in, my husband is 69 and has had great results with Seaboard D. I'm not
Yes.
sure if that's a typo or not.
Cyborg D. No, that is a type of chemo, Cyborg D.
Oh, okay.
Yeah.
He was waiting for autologous stem cell transplant and now delayed, and presently experiencing problems with poor kidney function.
Mhm.
Are there any suggestions other than drinking lots of water to help him?
Yeah, I can think of a couple right off the bat. First of all, if her husband had normal kidney function on Cyborg D previously and now it is getting worse, I think a couple of things that just come to mind is one is to make sure that the myeloma isn't getting worse. Often people who have light chain myeloma primarily that's about 20% of patients, are more likely to have some kidney dysfunction. And sometimes a person can look like they're responding well to chemotherapy, but within a couple of cycles, they're actually starting to show progression again. And so we have so many choices of agents to use these days. It's really important to make sure that he is responding appropriately to his chemotherapy. The second thing is that some of the drugs that are normally used to control blood pressure, for example, in particular, a class of drugs called ACE inhibitors, and those are drugs like lisinopril or benazepril. Some of those drugs can, particularly as a person goes on chemo, has a lower blood pressure, they can actually lead to some kidney dysfunction. And so a review of medications with, as Jim mentioned, with the team would be a very good thing at this point to make sure that both a question about myeloma response is addressed and also whether there are other situations, other medications that might be causing some kidney dysfunction, and then they could be discontinued and you could easily see recovery. I don't know if you, Jim, have anything to add, or Michelle?
No, Michelle?
I mean, the only other thought that I had is the over-the-counter ibuprofen is another one that,
Good point.
yeah, like you know, sometimes I think everybody definitely wants to get off their pain medication, and they think, buy over-the-counter ibuprofen, but ibuprofen is really, really tough on the kidneys. And again, since it's not prescribed, it might not be something that your doctor's aware that you're taking. So if he's using a lot of any NSAIDs, any naproxen, ibuprofen, those are also very hard on the kidneys.
Michael writes, Dr. Callender mentioned a second flu shot is being considered for multiple myeloma patients, but there's a question of coverage by insurance carriers. Should I approach my carrier through my doctor, or is there an effort taking place to do that at a higher level?
There is absolutely an effort to try to address this on a higher level, because particularly for people who are Medicare age, they may have found out, we have the recommendations for the revaccination, and I do have a slide for that I don't know if I can get it to John to distribute about what is recommended after a transplant. But for people who are Medicare aged and that's their primary insurance, it is hard to get those paid for. And we are approaching the American Society of Hematology to try to get their advocacy to actually get to Congress to change coverage for vaccines, because if you just want to look at it as a purely economic issue, they're cost saving. So if you can save a person from being hospitalized for flu, just like we have COVID vaccines underwritten now on a national level, it seems very logical that some of these other vaccines should be too, but it is a problem and you will probably have to talk to your carrier about it.
Yeah, that's too bad. Minna writes, thank you for such a good presentation on multiple myeloma. I'm a registered nurse who works in the outpatient setting. My question is regarding how to assist patients who've been newly diagnosed with multiple myeloma. What do you think are the most important things we want to establish with patients during their first meeting regarding their journey in multiple myeloma and prognosis?
Michelle, why don't you take that?
I think that what was spoken to earlier, that it's really, really important for it to be not only the patient but the caregiver at meetings, and depending on what each institution allows. For some of those first few meetings, when you're going through what you might have in terms of diagnosis, and once the diagnosis is made, even if your institution, like our institution, only allows one visitor, those are the meetings where you want to see if you can get an exception for more family members to be there, because it's an overwhelming discussion to have. And each person hears different bits. So having multiple sets of ears, I think, is incredibly helpful for patients. I think people taking notes is very helpful. And I think that this is meant to be a process. Like, we just blew your mind with your diagnosis. And so encouraging people to kind of keep a journal, to write down questions as they come to them when they're at home, so that the next time they come in to see somebody, that they can get their questions asked, so that they don't forget about them again. And I think that, you know, most of the time at these institutions, the nurses are so familiar with giving the chemotherapies, in terms of like side effect management and whatnot. Even just the nurse that's there at the bedside giving you your treatment may be able to answer your questions for you, or at the very least will likely be able to reach somebody like myself or Dr. Callender if the question's outside of their scope. But I think those first few meetings, allowing more family members there, it would be a really helpful thing.
Jim, could you address from, yeah, please.
I'm sorry, I got cut off. I have a cat that stepped in the wrong key and I was just totally gone. I think the last I heard, the question was about a new patient in the emergency room and what could be done. I think the first thing and the most important thing is education. We need to explain what this cancer is, and we need to at least start addressing some of those questions. I think the patient's questions will really guide how we respond to them. Are they someone who really wants a lot of information, or is it their caregiver who really wants a lot of information? I'm sorry I didn't hear what the other responses were, but I think the key to new patients and even established patients is continuous education about the cancer. I would also tell them to not be overly frightened by what they read on the internet, because that's the first thing a person in the emergency room is going to do, is go to the internet, and they're going to find that the life expectancy is much less in the record than it actually is. I think with Dr. Callender's fine treatment and all the research that we've had, a myeloma can be a disease that we live with and live with it a long time. And that patient needs to learn, needs to know that this is something that can be treated.
And I'm going to add a little plug for the NCCN patient guidelines. It's a good starting point for, thank you, Jim. It's a good starting point for answering a lot of the questions from diagnosis through treatment and so on. And that's available on nccn.org. Just a comment from Leah, who's talking about supplements. She says,
Green tea.
Green tea and Velcade do not mix.
Yeah, and there's laboratory data that is true. So yes, we do advise people not to have green tea. I think what you don't know is whether you should ever have green tea if you're getting Velcade, but at least there is some laboratory evidence to support that.
Okay. Here's a question from Veronica. She says, when a patient has had an autologous stem cell transplant, when a patient has had an autologous stem cell transplant last year and is currently on maintenance, in addition has had COVID vaccination, including booster as well as influenza vaccination, what are your thoughts of traveling between the US and Cancun, Mexico?
Well, that sounds like fun. I think there are obviously caveats, and I certainly think traveling without vaccination would not have been a good idea. One thing that this individual might want to look into is hepatitis A can be an issue in Central and South America, and that is a vaccine that's available. I think everybody's getting a little stir crazy. So some of my patients have traveled. We just advise them with mask wearing. If they are mostly outdoors, that would probably be fine. I think we're still pretty hesitant to have people, go to bars and crowded restaurants and hang out. So I guess I would feel a little bit uneasy about that. Certainly I can tell you that for the patients that have been vaccinated who have developed COVID recently, by and large, they've had very mild cases. But I think, traveling is still a little bit of a crapshoot to a certain extent about what you might encounter. So I think recently we had a patient who did this trip and went to Cancun. Like I said, they had intentionally decided to spend most of their time outdoors, which I think is probably the safest environment. But I think it's still kind of up in the air how widely, and we're seeing, right now in Europe that they are shutting down again. Austria, I believe, is going to complete lockdown. I think there has been a protest in Denmark about the same thing. So, it's a fluid situation, but I certainly think avoiding what I think we would consider high risk places like a club maybe, or a bar. I know most of the patients who have been told me that the amount of mask wearing is pretty minimal at places. So that would be my comment.
I think her answer is a good one, and I'd remind us that myeloma is certainly an individualized disease, and one person's myeloma is not another. Yep. If this person's had his or her COVID, have had the flu, they're on maintenance therapy, if their current control is pretty good, perhaps it is okay to venture out a bit. As Dr. Callender says, you really need to be smart about it. Don't go into a club where there's going to be a lot of unmasked people. But as I said in my slide, that our time is precious. And if you live all of your life sheltered without getting out and you have the chance, I think that's a negative too. So be smart about it. If you have that inner voice that says, I'm not sure about this, don't go. But if you're under good control and use common sense, you mask in certain areas, I think some travel is probably okay. And I know that's certainly an arguable position, but that's how I would look at it.
I would agree with that.
Yeah. Dr. O'Mill, this goes back to your discussion. How soon in the process do you recommend seeing a myeloma expert?
I would say the sooner the better. And I realize that patients don't know about myeloma when they're diagnosed. It's a new disease to them. But quite frankly, some of the early decisions you make in treatment can affect your ability to receive later treatments, your ability to get into a clinical trial. Local hematology oncologists know a lot about myeloma. They can get treatment started. But I think one of the things that should be asked right away of your local physician is, can you please give me the name of a myeloma specialist that you recommend? Or perhaps this is somebody that I've heard about. What do you think about it? So John, I think the answer to that is the earlier the better. The earlier you see somebody like Dr. Callender, the more directed your therapy can be, and the more individualized that it can become. Sooner the better.
Yeah, I would just add, the NCCN, I think, needs to be complimented. I think they've done a great job in getting patients information about, what things are out there, what kind of combinations. But and I don't want to feel like I'm, sound like I'm tooting my own horn, but I think, people who have good myeloma experience, particularly if your myeloma is not responding to your initial treatment or it is relapsed, I think that is an excellent time to bring in a person who really has deep experience in myeloma. I will just tell you, the amount of treatment changes in cancer is astounding. And to think that, a general practitioner, and they are fantastic. I mean, they handle all sorts of things, but it really is a lot to ask that they are, know every single nuance of every single cancer type. So again, if your myeloma isn't responding as expected, or you've had a relapse, for sure, I would seek out a center or an individual that has experience with myeloma.
And John, I would equate that to my experience in family practice. I knew that there were experts who knew certain things that I didn't know, and I had to have the humility to say, here's what I would suggest, but it's okay if you talk to Dr. X, because let's get their opinion. And one thing that a patient should always remember is that a good doctor is never going to mind a second opinion. In fact, a good doctor will actually foster second opinions to be sure that their decision is right.
That's great. That's good information for people to know. Maybe that's a good message to end on. I want to thank all of our presenters here. They had a lot of great things to say, and I appreciate you taking the time to talk about this. The NCCN Foundation would like to thank the corporate supporters of this webinar, GlaxoSmithKline, Janssen Biotech, and Oncopeptides. And again, a big thanks to our presenters and everyone who tuned in to listen. We appreciate your support. Thank you.
Thank you.
Thank you.
Very much. Thank you very much.